everyone. My name is Moyinoluwa Ajibade. I am a registered nurse in Mississauga, Ontario. I will be moderating the 1B clinical track session on leveraging educational technology to reduce barriers to care in sickle cell disease. This session will be recorded and the recording will be posted on the SCAGO website. If you or members of your network would like to refer to the information shared in this session. In this session, we will be hearing from Ms. Karen Fleming, who I will introduce shortly. Before I introduce Ms. Fleming, I would like to start with some housekeeping rules, which would then be followed by the presentation from our guest speaker and then a Q&A session. We kindly ask that you respect the learning being done in this space by abiding by the following housekeeping rules. Your microphones have been disabled for the duration of the webinar. If you would like to ask a question, please do so by putting your questions in the chat or the Q&A function. Or you could raise your hand and we'll try our best to answer all questions during today's session. Translation captioning for your preferred language is provided. To do this, click Show Caption at the bottom of your Zoom screen. Check the Enable Translation checkbox and choose the language you want the caption to be translated in. Please use respectful language in the chat. No profanity or inappropriate images or posts. Please do not post other material unrelated to today's discussion topic. Keep discussions and comments on the topic we're discussing today as much as possible. The SCAGO reserves the right to pause the session or to seek removal of participants who do not abide by these rules. Thank you for your understanding and agreement to the positive participation of today's session. Now that we have heard the housekeeping rules, I will introduce our speaker, Karen Fleming. Karen Fleming has been a nurse for 21 years, completing a Master's of Nursing in 2011 and her Master's of Science in Healthcare Simulation in December 2021. And she will be starting her Master's of Public Health with a Black Health focus in 2024. She currently works as a clinical nurse specialist in the Red Blood Cell Disorders program at UHN. She is one of 2 CNSs in our nation. Karen is an advocate for and a believer in the power of simulation to change mindsets and behaviors. She looks for ways to incorporate simulation into her educational designs for healthcare providers. Guys, help me welcome Ms. Karen Fleming.
Thank you very much, Moyinoluwa. It's a pleasure and a great honor to be here today. And it's great to see the names of people I know. Thank you guys very much for joining. And I'm just going to share screen. If you give me a second here. So, okay, I think you guys should be able to see the screen. If anyone cannot see it, maybe you guys cannot, just let me know. I think you guys should be good. So thank you again for joining today. I'm going to focus on leveraging educational technology to reduce barriers to care in sickle cell disease. I'm now in Tennessee, so I did want to just take a moment to acknowledge the land I am currently placed on. We recognize and acknowledge that we are on the historic homeland of the Chickasaw Nation, of which they inhabited. Memphis and all of Tennessee was the long-established territory for many indigenous peoples, including the Choctaw and Quapaw nations, prior to their forced removal and, for some, their unforeseen extinction. We have a responsibility to acknowledge the peoples and histories of these lands. So thank you for letting me take that. Today's presentation, we're going to focus on discussing why, I'm so sorry, this bar is blocking my visual, discussing why sickle cell education is essential for healthcare providers, highlighting the need for comprehensive care from healthcare providers for individuals with sickle cell, which we heard a bit about that in the Ontario Health session. Identify the benefits of virtual simulations and education of healthcare providers, and then demonstrate. We'll get to play the game of it, so we'll do that next. So why are we doing this? Why are we really talking about education for healthcare providers? And in particular, why are we looking at educational technology as well? I want to start off with some facts just on gaps, and I know many, for those that are on the line, this information you may know already, but just to make sure we're all on the same page. There's a study done in the States on patient perspectives of sickle cell management in the emergency department, and it shows gaps in care with respect to varying analgesic practices, provider bias, lack of provider knowledge, delay in care upon presentation to the emerge, and a number of things we have all heard across our centers. I feel regardless of where you're located, whether it's Canada, the States, I hear some of the same in Brazil, I hear it in the Caribbean. So the gaps and discrepancies in care are not specific to Toronto. They're widespread. So just to know, they are common, which is unfortunate. 60% of patients stay home to avoid the emerge, while 50% are satisfied with care. And I want you to take a moment to reflect and think, if this was an oncology patient, would those statistics be okay? Would leadership be fine with these statistics and not try to make changes happen? The second article I want to highlight, nurses' attitudes towards patients with sickle cell disease, a worksite comparison. In this study, they looked at nurses working on two different units in the same organization, emerge and critical care, to see what their attitudes were towards patients with sickle cell, since they do end up getting care in those two spaces. One thing they highlight is cue recognition and cue response are not aligned due to previous negative experiences in the emerge, which means that patients will recognize that they're having pain, but they will not respond with the next step of calling their nurse and asking for pain meds because of, I would even say, negative experiences just in emerge. I think if they had included an inpatient unit, they would have also got some data that aligned with that as well. That cue recognition and cue response are misaligned regardless of where they are actually throughout the organization. Patients are perceived as drug addicts. There's a reluctance to administer opioids, and there's a lack of sympathy. And the biggest thing for me that always kind of drives me a bit nutty is takes too much nursing time. Our nursing time is not like assigned, like nursing time is nursing time. So once you're at your job, you're working, you're providing your nursing care, to me, it shouldn't really matter where am I spending my time. I'm just doing my nursing care overall for all my patients. The last article, do words matter? Stigmatizing language and the transmission of bias in the medical record. I think this was mentioned probably in the Dr. Simpson's presentation, but to bring it up again, this particular study looked at residents who were paired with doctors, whether they were fellows or staff doctors, and they were looking at the notes. They looked at one note that was neutral, and they looked at another note that had stigmatizing language. And what they found is that when a resident would read the stigmatizing language note, their actions after that would be they would have more negative attitudes towards patients with sickle cell, and they prescribed less pain medications in particular. And so what we want to take away from that is that we can transmit how our behaviors, our decision-making of our colleagues will be based on words they read, words they hear, different little language selections such as sickler, which is a very negative word, it has a negative connotation to it. And so really being able to take those opportunities to identify that stigma and trying to change it and bring awareness to the stigma that exists. Lack of knowledge. Let me move this bar altogether. Titles, sorry. So lack of knowledge or lack of action. Individuals with sickle cell disease, okay, can't go anywhere else, fine. Individuals with sickle cell continue to face multiple disparities, as I've mentioned. Lack of provider knowledge is one of the biggest gaps. Providers feel this way, patients say they feel this way as well, and community supports caregivers also feel there's a gap in provider knowledge. There's not a lot of education provided to medical professionals, nursing professionals, allied health professionals, anyone, pharmacists, your physiotherapist, now, I actually wouldn't say social work. Social work gets to me a lot of, they're grounded in a health equity lens. So I feel like social work is one profession where there is some focus on health equity, but do they talk about sickle cell in particular? I'm not as sure, but certainly in healthcare provider education, there's a huge gap. And then when they come to the clinical setting, that knowledge continues to be a gap. And so you'll see this lack of knowledge contributes to increased use of acute care emergency departments. And this leads to more admissions. And this lends to the high 7 and 30-day post-discharge readmission rates for patients with sickle cell. And so at 30 days, it was, 30 days, I'm sorry, I don't have my notes in front of me, but 30 days, it was a readmission rate of, I'm going to come back to it. I realize now I usually have my notes in front of because I want to be precise. 7-day readmission rate definitely was 8% of patients. And I feel like for 30-day readmission rate, it was close to the 40-50%. It's too high. What I know is it's too high. Patients get discharged too quickly and they come back. And then this leads to increased morbidity and mortality. Briefly, just so you guys can see some of the ways that sickle cell disease related inequities present themselves in healthcare, whether it's emerged stigma, where they receive delays in treatment, they're denied care, mortality rate. There's a 21 to 35 year, for mortality rate, actually, it's not 21 to 35. There's more updated info. Mortality, I feel like now we're seeing more in the 30s, 40s, and the actual life expectancy is 56-ish, 56 years is what we're getting, which is 25 to 30 years less than other Ontarians. And suboptimal care can really lead to death and complications. Comprehensive care of SCD patients requires that affected individuals have a continual bi-directional relationship with their medical team. Patients need to be able to access the care they need when they need it, and the communication between the different services, it has to blend. There has to be a way for us to keep it seamless so that patients are not left with gaps in their care because the system is fragmented. So I'm going to move a bit change gears here and move into what a virtual simulation game is. Virtual simulations aim to recreate clinical situations perceived as authentic by healthcare professionals, I wouldn't just say nurses, and which problems are embedded. It tends to be built around detailed and complex clinical situations in which nurses are required to interact with a patient as they would in real life clinical practice. It is built on the tenets of experiential and problem-based learning. And so the picture there's of a nurse, and you can see the camera is attached to his chest. And that's one of our really well-made fake hot packs that we did for our game. But really appreciating once you see the game and see that the actual perspective feels like you are the nurse. The reason it felt like you were the nurse is because the camera was strapped to his chest. What are the benefits of VSGs in healthcare education? Increased engagement of healthcare providers. And so not only do I really enjoy and focus in on the education of healthcare providers, I want to understand how can we make it more effective? How can we ensure that what we're teaching is going to land and lead to behavior change? How can we ensure that this is actually going to decrease barriers and gaps in care and improve outcomes for STD patients? Improved clinical skill, because they're practicing as if it is them in real life. It allows them to practice those clinical skills and to improve on them because they can play the game over and over and over. They can play it as many times as they would like without any judgment. And this too is a piece. Virtual simulation games, it allows you to autonomously participate in it if you'd like, so that you're able to not feel judged if you get something wrong, or you can get something wrong and feel safe about it, correct it, maybe ask questions, know what type of questions you want to ask. You'll be better equipped for that. And so it does help also with your problem solving skills. The virtual simulation game I developed, I just wanted to give a very high level overview of what's involved in developing it. Once you've identified your gap and you know what your needs are, you've done your needs assessment, I'm sorry, and you really are appreciating what the gap is for your learner group, you want to select a scenario. I specifically selected a VOC, vaso-occlusive crisis of the patient in eMERGE, because that's the one we hear about quite often, and one in which we really need to change the dialogue to help our patients get access to the care they need. So learner outcomes are created, decision point map. Then there's a script creation. The script creation is, I want to say, is what takes the longest. And in my case, I had a warrior help me with it. So BScN Howell, who is one of our, is the co-chair of PAC, the Patient Advisory and Advocacy Council. She was the actress in in the game, and so you'll see her. But I made sure she looked at the script, to make sure we were being authentic and not misrepresenting anything around experiences of individuals with sickle cell. Yes, she's one warrior, but I feel having input of one warrior over us as healthcare providers trying to figure out what the patient may be experiencing is certainly puts us at an advantage. Filming itself, it took 8 hours, just packed it into one day, just ensuring that we were really organized with that. And then game assembly took some time. I won't get deep into this because people can ask if they really want to know about game assembly. I can tell you more about that. And then I had 20 nurses from Emerge play the game, and then I debriefed after. So the 3D model debriefing, if I was talking more in a simulation conference, I'd break that down more, the 3D model debriefing, but it's just really to highlight that after they play the game, we talk about it and we highlight what did you feel? What did you notice? One thing I got the most out of this is people did not appreciate the amount of bias that exists and the stigma that exists for patients with sickle cell, which is exactly what we want. You need to acknowledge and be aware of it first before you can really do action. And then I did an evaluation. So before we play the game, I really would like please to participate by logging into menti.com because I'll have some interactive questions for you. So you can either scan the QR code that's on the screen, or you can go to menti.com and enter the code you see there on the screen. I'll give you a second, and then I'm going to put up the Mentimeter screen, which will still have the instructions. So not to worry, if the instructions disappear for 1 second, please know I will put them back up shortly. So this game I didn't mention, I created this as part of my master's in simulation. It was the work I wanted to do to help complete my degree, and I wanted it really to be meaningful. This is BScN, a warrior who really helped me to ensure the whole thing was kept authentic in nature. The Mentimeter you guys will need once we get into the game, there's questions. Okay, so for right now, if you're wondering when will I use this Mentimeter, it's coming. We're just gonna get into the game and then I'll let you know when you need to use it again. These are just little statements. If you were into the game, if you actually were playing the game, you could read those statements that kind of just let you know how the game works, but I'm walking you through the game. The learning outcomes, I was very deliberate. Demonstration of accurate assessment for a patient diagnosed with sickle cell disease presenting with a vaso-occlusive episode. I would change the language now to episode instead of crisis in the emergency department. Prioritization of interventions based on the assessment information gathered from a patient presenting with VOC in the emergency department. Identify the correct time frame for the administration of the first dose of opioid from arrival in the emerge. And then identify the impact of implicit bias. Identify the impact implicit bias can have on the healthcare experience of patients diagnosed with sickle cell disease throughout their hospitalization. So the next page is going to show you now our case study, our introduction to our patient. Shauna McCrae is a 30-year-old female diagnosed with sickle cell disease who has arrived at your community hospital or your very regional hospital, just depends where it's located, but emergency department in excruciating pain related to the vaso-occlusive episode she's having. She's been scored a C-test level 2, which we know is exactly how she should be scored, and she's currently in an acute care room waiting for the nurse. You're now walking into the room to introduce yourself and meet your patient. I'm going to turn the volume up, and you should now be able to.
Hi, my name is Lloyd Francis, and I'll be your nurse in the emergency department today.
I'm in so much pain. Can you please help me?
Yes. Is it okay if I complete my assessment first?
Sure.
Okay, so first question is on the screen, and give me a sec. I'll pop it up on Mentimeter in a sec, but let's look at it together here. What are the priority components of an initial assessment for a patient with sickle cell presenting to emerge with a vaso-occlusive crisis? Select all that apply. So I'm just going to go over to the Mentimeter to show the question to you on your screen so you can go ahead and answer it. Oh, I have a pre-self. Oh, thank you guys for doing the pre-self assessment. So if anyone didn't do the pre-self assessment, it is on the screen now, so you can complete that because I can see we've got some more people who've joined. And I also will I feel like I do have a moment to go back to the code in case anyone missed the code, because I know people might have joined a little later. You can grab the code there. Okay, 5130-4680. I might ask one of my colleagues who are helping to support the session, if you can just note the code here, the 8-digit code, in case anyone else joined, then you can just pop it in the chat and they can join the discussion. Thank you. Okay, so let's go to question 1. What are the priority components? So fantastic, people have started answering. And so yes, the top options I see here, pain score. Absolutely. Really important for you to qualify where is the pain level at for the patient at this current time. Vital signs. Yes, you absolutely need to do vital signs on the patient to have a sense also, how are they physiologically doing? Dose of opioid that has worked in the past? Yes. Thank you for the 3 that answered that. Wonderful. You need to know what has worked in the past and then to take that information and to take the patient up to a higher dose. What often happens is the patient will say, you know, I was taking 5 milligrams of Dilaudid at home, and the provider will say, okay, well, I'll start you at 2 milligrams then, IV. And it just doesn't, it's so, what would I say? It's almost like discounting the patient. You're not listening to the patient when actions like that follow, because you're starting off lower than they were at home, and therefore you're not really actually addressing the need in which they've come to you for. The last 2 I see here, pain regimen at home before arriving in the ED. Yes, 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 right? Oh, sorry, that's the one I just did. And the dose of opioid that has worked in the past. That could be in reference, I'm sorry, to previous admissions. What has worked in the past when you come in the door with a VOC crisis? Where do you usually start at so that we can be very similar to that place to help expedite care for you and help you get out of the emerge? A head-to-toe assessment is not a priority component. If you think about a head-to-toe assessment, right, like eyes, ears, nose, all the way down, throat, chest, no, this is not a priority component. You need to do this, but not up front. You do need a CBC though. Okay, so we do want a CBC at some point, along with the head-to-toe assessment. So the 4 things: pain score, vital signs, pain regimen at home before arriving, and dose of opioid that has worked in the past. And so let me now put that up here in our answers so you can see the next video. So pain score, pain regimen at home, dose of opioid that's worked in the past, and we said our vital signs.
Now that I've completed my assessment, I'd like to clarify your pain medication regimen. You normally take hydromorphone PO 5 milligrams every 3 hours as needed, correct?
Yeah.
And during your last hospitalization, you required hydromorphone IV 2 milligrams every 15 minutes for the first hour as well?
Yeah.
And so one thing I want you to just pick up on there while the nurse was reviewing the previous history of the patient is when she came in before, she needed 2 milligrams Q 15 minutes. And so I feel that's one of the pieces actually that really we could do better on across the world. How do we get back-to-back doses to patients quickly in the emerge so that their length of stay is decreased? It will be dramatically decreased. They may not even get admitted. If we could really tackle, get there within the time frame, I won't tell you because that's a question coming up, but get there in the appropriate time frame and then do the back-to-back dosing for the patient. So the order sets, like, our emerge colleagues, make sure the order sets have that Q 15 to 30 minutes, whatever that time frame needs to be to ensure the nurse doesn't have to follow up with you. Make sure it's actually embedded within the order set and really acknowledges the need for rapid treatment. Okay, we're only going to do 2 questions for this game. I'm not going to do all of them, but I just wanted you to get a little flavor. So here's the next video for you. So, when should a patient with sickle cell presenting to the emerge with a vaso-occlusive crisis receive their first dose of an opioid? Within 45 to 60 minutes, 30 minutes, or depends on how busy the department is. So, thank you. So we have one person who said within 60 minutes of arrival, and then we have some who said within 30 minutes of arrival. And so it does depend. Where are we, from triage? So when I first did this game, I didn't include from triage in my statement. I just want to make sure. Okay, thank you. And so from triage, it is 30 minutes. Okay, so definitely that is correct. The 60 minutes is also correct if we're saying from registration. Okay, so just to know the difference. Registration usually is first, so that's 60 minutes, but from triage, 30 minutes. They should be being seen. They should be receiving their first dose of opioid, which means, the order should be in, it should be prepped, ready to administer, and inside the patient's body within 30 minutes. And it can be done with appropriate protocols in place, awareness, and a commitment to this patient population for them to have the best care and access to that care rapidly, so that they don't end up being in the emerge too long, they don't end up being admitted, and they don't have to have all these negative experiences that prevent them from coming to the emerge in the first place. Okay, so now let me go to the slides. Okay, so I'm gonna come back in now. Sorry, let me answer this question so you can see the last video here. So the answer is 30 minutes.
Now that we've been able to get that first dose in less than 30 minutes, let's try to stay on top of getting your pain under control.
So always in the answers, obviously providing some direction to the learner so they know what they may have done correct or incorrect. So normally after the game, I really would do a debrief. I'd open it up, but I'm going to continue because there would be some discussion. And at the end, we can always, if there's any questions, feedback, we'll just do it all together at the end. The second example I'd like to show you is an escape room. This I just recently created. I just created it in September for some residents, along with a wonderful team at UHN that I got to work with to create some education for residents that would be spread across Toronto. So it was great to be able to have a pocket of residents who are going to various hospitals, emergency residents, going to various hospitals. And we spent 3 hours with them, which was wonderful. And so part of it was didactic, really learning about sickle cell itself, what are some of the care concerns, some of the presentations you'll see, biases and barriers to care. And then we had a patient panel, so having the opportunity to listen to warriors, their experiences, and ask questions and engage with them. And then the end was this escape room. An escape room is a highly effective way to deliver education because you're able to put multiple things within the escape room. It has a gaming component to it because there is a timer, there's a little excitement that can be drawn from it, which can really help people to participate. So give me 1 sec, I feel like. Okay, there we go. So if I swoop, okay, I'm sorry guys, let me just go out of the switch once we got there. And let me see, there we go. Let me just bring up the actual site. I just feel like it's not doing what I wanted to. Let's bring it up. Yeah. Okay, so this is the site itself. It's a Google site, just in case anyone's Google, Google-less or Googler, just to know that this is a Google site. This is a STEM, or the intro to your scene. It's a Saturday night at 2:30, and you are the resident on shift in the emerge at TGH. This could be obviously changed and tailored. And so the providers themselves, they read through this information and they're told there are 7 clues that they have to discover in 2 minutes. And that they can also use an SOS only once, if they'd like to call the doctor who is covering the emerge, Dr. Brian in this case, who's here today, thank you very much. They needed to reach out to their ED staff doctor. They could. So there's an SOS button at the bottom. And when they click this button, a phone number came up so that they could call the doctor. They have a timer here that they have to activate when they come into the room. So they just click it. And so what I think this is really useful for is if you have big groups and you want to put them into small groups. So we had groups of 4, like teams of 4, and they would work around one computer, but everyone is working at the same time. So that competition piece is there that really, pulls up that anxiety and helps with the learning. You want people to have some anxiety when they're learning. They learn better, but not too much because then it blocks the learning. So we do want you to feel challenged. And so I will hover and just show you a few places where I have hidden the clues. There's one clue right here, the armband. The exclamation mark is a second clue. The ID pole has a clue. The number 4 is clue 4. I feel like over here, yep, on the wall itself, resources is clue 5. Did I have the curtains or something? Okay, so that one just hover. I can't remember where the other ones are, but there's 7 and 2 because the pillow is a clue. And then there's a clue within a clue. So when you go to the resource room, there's a clue in the resource room. I am going to start off with the resource room. So when the learner prints it, of course, this is exactly what they'll be next to. They'll read this, they'll look through it, and have to figure out, well, what do I do here? Well, you just start clicking. It's like an escape room. If you've never done an escape room is when a group of people are locked in a room basically and have to use the clues in the room to escape the room. So there's sometimes no rhyme or reason, just get started. Just start looking for some clues. So in this case, we actually want you to start clicking, right? So canine, this is going to take you to the canine site, but oh, look, actually, it's not even the canine site. Instead, it's video. So this is meant to deter you. This is a trick. You're not supposed to use that one. If you went to the health quality standards, you will get taken to the quality standard page, but it links to another clue in the game where the patient told you that one of the quality, the patient actually asked you, do you know there are 2 quality standards that are really pertinent to the emergency department? And so if you haven't clicked on the pillow to start out to talk to the patient, you wouldn't know that there are 2 quality standards that you will need to know to help you get out of the room. So this is one of those ones where you have to put all the clues together. And I'm happy that I gave them 10 minutes because people got out in 10 minutes. So the residents were able to successfully escape the room, which was fantastic. And it helped to reinforce for me because it was the first time. So to reinforce, okay, the timing is right. I asked them, did the learning needs, did it match? Did the escape room match what they'd learned throughout the day? They did confirm that. And, and was it an engaging, interactive way of learning? And they did also say yes to that. I want to show you one other piece, or I can even show you the video actually of the patient speaking. And then I will move on to the last thing I want to show
So you're my doctor, I'm guessing? Okay, great. I've been here for over 3 hours and I haven't even been looked at. I haven't even gotten any pain meds, so if you could put an order in, that'd be fantastic. I don't remember what they gave me last time. I'm in too much pain to think right now. I don't know if I have any allergies to anything, but my chart should tell you all of that. And as for, I don't know how long you've been here, I don't know how long you've been working here, and I don't know how many sickle cell patients you've actually seen, but Ontario Health just came out with quality standards, but there are 2 specific to my situation here in the emergency department. I'm hoping you know them.
So I'm going to stop sharing this one just for a moment. And so really that purpose is to remind the provider that you actually should speak to the patient first. Because if you speak to the patient first, it helps you to get around the escape room better. And to also remind us to listen to the patient, right? So not only is it about the building of the escape room, what components will you use, but what behaviors do you want to replicate in your provider team or whoever's actually playing the game. So let me just see, I've got a few more minutes. Let me just find another game I wanted to show you guys. This one is for children. So I'm going to open it up. I'll just get my link open here. Okay. And I'm going to share the screen one more time. So this game is called Grace. Game to raise awareness for patient provider public education of sickle cell disease. And so this for me is really good for children. It is my sense is that it could be for anybody, honestly. But children would really, I feel, gravitate to this. Your younger children. So if you're in a pediatric center, maybe it's for a sibling. You want to help teach a sibling about sickle cell, or you want to teach a caregiver about it. And maybe you just want to keep it a bit more simple. So when you click here to start, and you can just find this honestly online, but I can absolutely put the link in the chat. It'll tell you, welcome to Graves, this is your red blood cell, and you can customize it. You can say, well, I want some sunglasses, I want a cape. Yeah. Oh, you can only pick one. Okay, so I'm gonna pick cape. And click on the module to start answering, right? So there's different things it's gonna show you. There's science, treatment, society and demographics, myths, and symptoms. So regardless of which one you go on, it's gonna take you through, show you some information. And you can also click on boxes to answer questions, which I obviously didn't read the question to really know what answer is supposed to be, but to know that it's meant to engage you a bit in a different way. And I think kids would really tend to really connect to this, and multiple people, because it's not too much jargon, and it really helps to narrow down what is a sickle cell, and you'll get to see different shapes and that kind of thing. Oh, can you guys not see this? Because it's telling me new share. Can you guys not see something on the screen right now? Maybe if I get a thumbs up, can you see the screen?
Yes, we can.
Oh, perfect. Okay, thank you guys so much. Just wanted to make sure we're linked up there. Okay, so we present here, and that's really what I have today. If there's time, I have some time for questions. Those, and then outside of that, of course, I am creating the and I'll stop sharing my contact info. I can absolutely just give it to you guys. The other education I'm creating that's been mentioned a couple of times in the summit is the healthcare provider educational modules. And so those are e-learning. They're more, mobile learning, and they do have some interactive components to them as well. So they're also something else that can be used as a part of education. We are going to have the program completely developed, certainly as we go into the new year. We're aiming to have all the modules ready to go. And so right now we've got modules 1 to 4 available if you do want to start on your education. And then we will be adding more and more modules as we get through the end of the year, so that by the beginning of next year, we have all 13 modules there and people can just do the whole program. So thank you very much. Are there any questions, any discussion?
I just want to thank you, Ms. Fleming, for this amazing presentation. I just remember, like, back when I was in nursing school, being a student nurse, like, I had a couple of patients with sickle cell, and just seeing some of the nurses talk about, oh, this person is just a drug seeker, it really hurt me. But I used to be part of this organization in Nigeria, and that's how I was able to have a little bit of knowledge about sickle cell. And I know we used to call sickle cell people I'm sorry, patients with sickle cell, we call them warriors. And ever since then, I'm just like, oh my goodness, these people are like so strong, and just seeing them fight through the pain, through it's just a lot. And I'm glad I was there to be able to advocate for those patients and just like kind of educate the nurses that these people are actually in pain. Like, in nursing school, they teach us that pain is what the patient says it is. Like, it doesn't matter how you think they're feeling, they are feeling the pain. So it's just really helpful to hear it again and just like re-educate myself. And speaking of knowledge, I went through the simulation yesterday, and I must say it's really good. Thank you so much.
Oh,
Thank you.
I appreciate
Yes.
Thank
I'm just Yes, ma'am. I'm just gonna see if we have any questions. Um, yes, we have one. So, how can folks who have experiences like the one I just mentioned contribute to the HCP modules?
So I think that one of the pieces that didn't get shown in the virtual simulation game is one of the last questions that get asked is one of the nurses goes out, like the same nurse goes out to the nursing station and says to another nurse, oh, hey, can you help me out with my patient? And the other nurse says, oh, what patient are you talking about? And he says, oh, Shauna McRae in room 434 or whatever. And so the other nurse says, oh, that frequent flyer. Let me tell you something about sickle cell patients. They just are drug seekers. No matter how much you give them, it'll never be enough, right? And then it cuts there, right? And then your question comes up. You know, how would you deal with this situation? Would you address it with Lindsay? Would you actually talk to the nurse, Lindsay, the other nurse? Would you talk to Lindsay about it? Would you contact the manager to let them know about the behavior, or would you do nothing? And so it really depends on which group of learners I'm with. If I am with nursing students, they are going to contact the manager. And I understand it completely. They are new, they are too vulnerable, they are the lowest person on the totem pole going into a new area. They are too fearful. So contact somebody. So I think going to the manager is one strategy as you try to build your confidence, because everyone is not going to feel immediately comfortable speaking to the nurse directly. Even after years of nursing, there's many people who won't feel comfortable actually saying, no, Lindsay, your comment wasn't quite appropriate. It made me feel uncomfortable when you said frequent flyers, like you were trying to imply that patients with sickle cell come here because they want to, not because they need to. And so really, I think part of the game playing is that there has to be dialogue. So, that's why I do like handing out the link for the game, but I feel like if you do it on your own without some dialogue, some conversation, you might actually not get all of what's meant to be. So when I do the game with nursing students, it is a bit about implicit bias. We play the game and then we debrief it completely, so they're getting the full opportunity also to speak about their own experiences. Like, what have you seen when you guys are, even as students, like what have you seen when you're paired with your preceptor? What have you seen now that you're as a new nurse? What have you seen other colleagues on the unit doing? And a lot of it is culture, right? So the culture they're in, sometimes, although nurses know it's not the right thing to do, the culture sucks them into doing it. And I don't know how to explain it, but if all the nurses on the floor are all saying sickle cell patients are drug addicts, although you don't feel that way, if other nurses are saying it, you don't want to be the one standing out to be like, no, 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 they're not. When you're new, I'm really talking about this power differential that exists when you're new, because you have to think about your own longevity also. Like, how do I talk about it? I need to address it, but how do I do it is I feel like it has to be carefully thought about, because otherwise you'll get ostracized and you'll get bullied. I'm just being honest and candidly, right? Like, if you try to go against the grain, you might get some, especially as a new grad, right? Oh, that new nurse came up in here and she's trying to change our practices. Well, that's okay, but that's not how it gets received all the time. So I do think it has to be conversations, and I feel like leadership has to also be a part of this, to say this is not tolerated, this is not okay. And performance management, there has to be some consequences for behaviors. How can you treat a patient and say, well, I don't really believe you're in pain? Oh, the phone one's there for sure. Okay, in case anyone's thinking, the cell phone one, right? So Fitzanne's on her cell phone at one point and she says her pain's an 8 out of 10, right? My pain's 8 out of 10. Yeah, and could I get a little something more for it? And so often providers take that as, how could you be having pain? You're on the phone, you're smiling, you're in a conversation. You can't be having pain. Yeah, distraction techniques that we do in pediatrics, distraction techniques in adults, right? It's just that we don't really tend to talk about distraction techniques in adults, and we're in this continuous mindset of drug addict, opioid addiction. And so we need to get out of that mindset. And I think that helps with some of this education that we're speaking about. So thank you for that question.
Yes. I do have a question for you. So, have you seen any tangible impact or change for patients after the healthcare providers engage in your games? Because I know, for personally, I did learn a lot, and I'm just asking, like, have you seen any tangible impact?
So I think it's an awesome question. When I did the game at North York, because that's where I was at the time, at North York General, I saw anecdotal impact immediately. So there's always that, right, that case where someone had learning and then the next day they had the patient in which they learned about, right? And you're so thankful they had the learning because they knew what to do. And so, yes, so they too recognized they could be more empathetic. We need to be more empathetic and just patient and listen to our patients. And so they felt the care they provided to the patient, that they could provide it in a different way. They contacted me right after, like, oh my gosh, Karen, I just got a sickle cell patient. And the patient themselves said, the care I've received during this visit has been outstanding, or something in a positive way. It has been different than the past. It is better than before. So it is anecdotal, a few here and there, certainly more opportunity to really study that. But so far, I think bringing awareness up front to nursing, to providers, it helps you in your decision making to stop and, okay, hold on, am I really being objective here? Let me take a moment, let me take a step back, let me remember what I learned, and let me now address the concerns of the patient. So yes, thank you for that question.
Yes. We don't have any questions yet, guys. Please, let's ask Miss Fleming questions while she's still here. But I do have one more.
Okay, thank you.
Um, if simulation is proposed as the best way to help healthcare providers like myself to retain knowledge and gain comfort in the skills that we may not use often, like you mentioned, like at North York General, they did the course one day and the next day they had a sickle cell patient. Like, it's so far in Canada, I've not had any sickle cell patients. Like, the only sickle cell patients I've had are back in the US.
Mm,
So, I mean, I guess it could also do with like the unit I'm currently on. But how come this simulation is not included in like hospital education programs and even pre-licensure schools? Because I know like how important it is. Like it's really really important. Because again, I've also like heard a lot about other blood disorders like cancer, like the blood cancers and everything. But I rarely hear about sickle cell. I don't know what can be done. Like how can we go about this?
Love it. So I think that the biggest gap certainly is including it, first of all, in healthcare provider education, right? And so how do we do that? So I've thought of a couple different strategies. So what I first started with was just really reaching out to schools and saying, listen, I got some knowledge around sickle cell. I feel like nursing students need it. And so how can I come and collaborate with you to deliver it? It's worked for a couple schools. I've done U of T. I've got Humber lined up, and I'm going to be spending some time at another school soon as well. But that's not really, that's just still piecemeal. I feel like it has to almost come from the Canadian Association of Schools of Nursing, and from there it needs to trickle down. And they have, released the it's a health equity framework or something very similar to that, or reducing racism in nursing. It is very similar to that. That's one of their foci for the Canadian Association of Schools of Nurses. So I think that being able to tap into those bigger overarching groups that have the bigger impact across the schools is one opportunity to really increase the inclusion of that education. When it comes to simulation in particular, I think this still comes back though to different organizations and where are they at with the buy-in of simulation. Not all healthcare providers think simulation, that they're not bought into it and into the actual benefits of it. So active learning strategies, hands down, you learn better when you're actively learning, you're participating in it. I'm replicating what's relevant. I'm replicating the behaviors in which I need to do in my work. That tends to stick better. But it depends on funding, who's in charge, who actually truly believes in it, who's leading it, what information is being given to you about simulation, right? Some people might not look at the escape room as a simulation, but it is. It's a recreation. It's an emergency room. The questions that you're being asked are about a patient you would see, and the questions are posed in a way that they relate to the way in which you would work in your role. And so simulation is simply a recreation of reality. That's simple. That's, to really simplify it. So even if you do a case study, that's simulation. A case study, it's about a patient, right? But to me, now, do you take that and do you debrief it? Yes, usually. But people don't tend to call that simulation. A lot of people think of simulation to mean a mannequin. That's, for me, yes, a mannequin is one form of simulation, but how do we take it away from mannequins? Because for sickle cell in particular, I can't even think about mannequin based like what would you want to do mannequin based? Because you need a person. Either you need to have a patient who's in the room, right? An actual sickle cell patient that the provider has to go in and has to practice. How would you provide care to this patient when they are writhing in pain or they're silent in pain? How are you going to ensure that they get the care they need? We can simulate this, but we need patience. To me, if you just have a mannequin, you will not get the same interaction. I need to be able to get that verbal communication, that interaction with the patient that really gets missed sometimes. Listen to the patient. Like this, I hear over and over and over again. I'm actually in Tennessee right now. I'm just completing a sickle cell nursing boot camp that I've been here since last Sunday. That's what I heard it over and over from the patients, from the healthcare providers. Listen to the patient. So for me, what is the gap in knowledge that you're trying to address with your simulation? That's the biggest thing. What is the gap and what are the objectives? And can it be met with simulation? Because simulation is not the answer for everything. I'm certainly not saying that, but I am saying that dependent on your gap and your objectives, if it can align with an active learning strategy such as simulation, it should be highly employed or, certainly selected as a choice. So I just think it needs more time, more people's mind.
Yeah. Wow. We have another question, and it feels like this person is actually in my head. So, do you have any advice for early career nurses like myself who would like to become the third CNS in red blood cell disorders?
Guys, I love it. Okay, first of all, let me put my email in the chat. Okay, for anyone who wants to reach out, I am a complete, I don't think I can. I think based on my thing, I don't see in everyone. So I'll send it to host panelists and then you guys can post it because for some reason I can't post it. What I would say. So first, if you were committed to learning about sickle cell, then first of all, join SCAGO. If you're a member of SCAGO, if you're not a member of SCAGO, first of all, start there. Join SCAGO because the networking opportunities, the resources that are available, the educational modules that are being created, there's a great deal of opportunity to be continuously exposed to sickle cell and to the experiences of patients. Because I feel like that is the big thing. What is the patient experience and how can I make that better? I think that you have to do a lot of your own education, to be honest, because there's not, yes, there's the healthcare provider modules that are coming, but there's not, again, there's not like nursing school, right? There's nothing. So to me, there's a lot of self-commitment. Even like when you think about equity work, I have to do my own self-work in order for me to build my knowledge to then move forward. Getting onto a hematology unit. So if you guys are early career, maybe try to get on a medicine unit where you'll see sickle cell patients, an emerge, you will see them in critical care, but not as like, I feel like an emerge or general medicine unit, at least work with them. I interact, find a way to get into a position where you're able to actually work with patients. And then you're able to be an advocate. And then you're able to grow your knowledge and your expertise in sickle cell. It took me 21 years, guys, for me to get this role. And my director actually created it for me. I applied for RN and then I called her up. So you have to be your own self-advocate, right? I called her up and I said, hey, why didn't you hire a CNS? And she's like, I don't know. I was like, well, let me tell you why you should. And so I told her exactly why she should. And I swear to you, less than a week later, she emailed me and she said, I talked to operations and I've already talked to the red blood cell team and we are going to add this role and you are going to be the only person interviewed for it. It wasn't even posted. It was just, come, let's interview you, because of the excitement on, not excitement, sorry, the passion in which I tend to convey about sickle cell. I can't help it. I'm passionate about this, people. I can't understand it. Actually, for me, in my mind, I actually can't understand how as healthcare providers, we got into this profession and we treat patients this way. It's very disconcerting to me. I listening to my patients tell me about the struggles they face and why they will not go to the emerge. And I have to be like, no, you really need to go to the emerge. Yeah, I can hear from your shortness of breath that you need to be in the emerge. And they're like, no, I'm not going because when I go there, I get treated like I'm a druggie, like I'm a drug addict. So they stay at home, suffering in pain, treating themselves and suffering slowly because they want to avoid the treatment from people. It's not even like the care is available, but they're trying to avoid the treatment they receive, interpersonal treatments they receive from us. It's not, and it cannot be denied. It is anyone within their encounter, whether it's the person at the registration desk who questions them like, oh, you're here again? Or the pharmacist they go to when they go to pick up their meds and the pharmacist calls us and says, did you really write this prescription for this patient? Right? It's this continuous fight they have to do to defend their disease. And so yes, I don't know where it's going with that, but my email's there. So
Thank you so much. So we have one question. Do any of your games include scenarios for pregnant patients experiencing a pain episode? So Miss Simone here is a midwife, and she recently overheard nurses discussing a patient who arrived to the L&D triage in crisis. So the patient was admitted eventually to the ICU for pregnant patients, and the ICU nurses were questioning the dose of opioids that had been administered in the triage department.
We do not have a game, but thank you, feel free please to do the poll as I finish up this question. But during the summit, there should have been some opportunity to fill out a needs assessment, and perhaps it's coming or I might have missed it, exactly for this. It's a needs assessment on what would you want included in an educational module for pregnant patients, reproductive and sexual health. So anything, pregnancy, conception, infertility, fertility, whatever that looks like, what would you want in the module? That module is coming. And so that is certainly coming. When it comes to VSG, not yet, because I do want to do that, but I need to do a second game first out of the emerge. I need to do one on the inpatient unit. I really need, there needs to be some connection because that is another big gap is when they move from emerge to the inpatient unit. All of a sudden they get onto inpatient, they're being flipped to oral or being encouraged to flip to oral and get, off you go. You're good. You don't need to, you don't need to stay literally as they arrive on the unit. And so just needing to really, take care of that bias. But yes, the pregnancy piece that will come out in our modules certainly by next year. So thank you for that question. I love it. Thank you, Simone, for bringing that up too.
Perfect. Thank you so much. And I do not see any more questions. Guys, please let's do the poll. I see that it's up already. And while we're doing that, I just want to thank SCAGO for giving me the opportunity to moderate. It's my first time, and I definitely had a great time with Miss Fleming. And I also want to thank Miss Fleming for this presentation. It was really knowledgeable, and I learned a lot, and I'm sure a lot of people did as well. Finally, I'd like to thank all the attendees for joining this amazing session. We would not be here without you guys. Thank you so much. Enjoy lunch and make sure to join one of the next tracks coming up at 1:20 p.m. Thank you, guys.